Thank you, Kara, and thank you everyone for bearing with us with the technical difficulties. But on behalf of the National Coordinating Center, my name is C.B. Memrill, and I'd like to welcome you all to today's Research in Progress webinar on strategies to achieve alignment, collaboration, and synergy across delivery and financing systems. We have a great topic for us today, which is implementing a culture of health among Delaware's probation population. And before we get started, we'd like to first acknowledge the funding and support of the Robert Wood Johnson Foundation. And I'd also like to remind everyone that at any time for today's presentation, if you do have questions about the presentation, you can type your questions at the lower left-hand corner of your screen where you see the chat box, and we'll try to get to your questions at the towards the end of the webinar. So without any further ado, I'd like to introduce our speakers for today. First, we have Dr. Daniel J. O'Connell, who is a senior scientist with the Center and assistant professor in the Department of Criminal Justice at the University of Delaware, where he teaches criminology. Daniel's research specialties are research design and methodologies, intervention development, and project management. He is currently principal investigator of a Robert Wood Johnson project aimed at improving access to health care among the Delaware probationer population. His other projects center around improving evidence-based practices in corrections and law enforcement, and his publications include articles on drug treatment, prison management, HIV prevention, interventions, program evaluation, and criminological theory. Our other speaker is Dr. Christy Visher, who is director of CDHS and professor of sociology and criminal justice. Christy is principal investigator of the NIDA-funded collaborative criminal justice drug abuse treatment studies, which studies organizational strategies for improving the implementation of evidence-based practices for substance abusing offenders as they leave prison and return to the community. Prior to joining the University of Delaware, Christy was principal research associate with the Justice Policy Center at the Urban Institute in Washington, D.C., where her work included Returning Home, a longitudinal study of men and women released from prison in 4 states. Her research interests focuses on communities and crime, substance use, criminal careers, the role of social factors in criminal desistance, and the evaluation of strategies for crime control and prevention. She has published widely on these and other topics in numerous social science journals, and she has also co-edited the Journal of Prisoner Reentry and Crime in America. So with that, I'd like to turn it over to you, Daniel and Christy.
Okay, thank you very much. Thanks, everybody, for taking time out of your day to for being here. And we want to thank the Robert Wood Johnson Foundation and the fine folks at the University of Kentucky. We want to talk today about our project, Implementing a Culture of Health Among Delaware's Probation Population. I want to stress that this is a research in progress presentation. We're not going to be presenting findings, but we want to walk you through kind of what we intended to do, what we started to do, how we're doing it, and what we've learned since we've been in the field, as well as some adjustments that we have made to the project as a result of our time in the field. And there you go. All right, so there were 4 elements to the systems for action that could be applied to, and we covered a number of those. And what we intended to do was to use a local change team, which I will describe in some more detail in a minute, to look at aligning systems, multiple systems, to focus on reducing health inequities. So we're looking at working across different sectors of the public delivery system to bring them together to focus on one particular problem, and we're doing that through using a local change team. We did not apply under the systems for action. One of the things you could apply to was the use of incentives. If you look at the card, the slide there, it says stay tuned, because we are actually modifying our project to include some. I'll get to that as we move forward. So we have 2 problems that we're trying to address. There's a people problem and a systems problem. Lots of folks focus on the fact that we have 2 million people incarcerated in the U.S., but what gets less attention is that there are 7 million people who are on probation, often the same folks. They cycle in, they cycle out. But the majority of people are actually in touch with the criminal justice system through a probationary setting. But they face a lot of the same health issues as the incarcerated, partly because they're the same people, and they represent a hard-to-reach population. They tend to be minority, they tend to be young, they tend to be undereducated, they tend to be underemployed. Just a few things from what data we have, and I'm not going to read this whole list, but you can see that on most of these measures, depression, anxiety, they are more likely to have experienced these than the general population. We get into some of them, like substance abuse disorders, between 3 and 7 times, but depending on which study you look at. And they are at a heightened risk for chronic types of diseases. So generally, this is a group of people at an elevated risk for a number of health-related issues that are not necessarily in touch with and getting continuing ongoing screening and treatment for those. Now, the system problem, so we have all these people on probation, but the probation departments are not generally, they do not see health as their responsibility. They're carrying out orders from a judge regarding behavior, and the departments of correction and probation don't really see health care as their issue, and it's not their issue. It is not. It probably should not be, but it is a place where people in need of care are visiting on a regular and predictable basis. If you walk into our Wilmington, Delaware probation office on a reporting day, you'll see 50 to 75 people sitting in a room waiting for an appointment with a probation officer, and they can sit out there for quite a bit of time. So we started talking to our probation folks in Delaware, and they saw health as an issue, but not really in their wheelhouse. They had no desire to take on the additional responsibility of doing screening or referrals or any of that, but they were willing to work with us and were willing to allow us to access that population, and that's kind of what started this whole thing. So we were working on that, and looking more at some of the Delaware probationers in specific, looking at barriers to health. Why are people potentially not getting the health care they deserve? Drawing on data that was collected in Delaware as part of another study, we see that over 80% have a history of drug and alcohol. We've got a pretty good proportion of seriously mentally ill, and again, undereducated, underemployed, facing housing issues. Transportation is an issue for this group. Only 14% have a valid driver's license. And we have, a lot of family issues and the stigma of being on probation. All of these present barriers for becoming attached to regular general care health in the community. So the system problem number 2 is that this is not just a probation issue, nor is it strictly a health agency issue, but there are often multiple issues affecting health, housing, education. All of these things impact people's abilities to link to and remain in contact with continuing and ongoing health care. So our approach was that we need to look across different agencies, across people doing different things, but bringing them together to focus on this one topic. And so we did. We brought together, Dr. Visher and I are familiar with the NIATEX change team approach. For those not familiar, NIATEX is the network for the improvement of addiction treatment. That's where it started, looking to improve practices in substance abuse treatment agencies. And what the NIATEX model does is it brings together teams of buildings, teams of people to focus on specific issues. They're often used within a single agency, sometimes across a couple of agencies. We are going to do it with multiple agencies involved, creating a complicated team. So the way it works the way a change team works is we bring together people. We do a lot of team building on the front end. We do empowerment to make sure all voices are heard, and to bring a group of people who have equal voices to focus on these And the data show, Dr. Visher and I did this before in a study in corrections, not in probation, but on the prison side, on the delivery of HIV services, using the local change team approach, and we had pretty good success with that. So we thought we would try it with this group. It's like I said, it's a slightly bigger team than we've used in the past. You can see the chart there. That's kind of our process model, if you will. And so we've got the Departments of Corrections, Health and Human Services, Housing, Labor, Education, Christiana Care Medical Team, which is the largest healthcare provider in the state of Delaware. They have 2 level 5 trauma centers in the state, and so they are really the largest group on the health side that we're working with. Department of Public Health, Connections Incorporated is a local service provider, outpatient, inpatient treatment, so they deal with a lot of the addicted population as well as the mental health population. Planned Parenthood was part of the team, and of course us, the University of Delaware Center for Drug and Health Studies. So we brought this change team together and started working on the issues, and you can see if you follow the flow there, we went through a series of brainstorming exercises. We conducted walkthroughs in which we went out to the hospital, we went to Planned Parenthood, and we went to some of these agencies. And the way a change team walkthrough works is you go through the process as a patient or as a client would. So we would go there, and it was kind of what happens when you walk in through the front door of Planned Parenthood. How does one get enrolled? And we go through all of this. How do the insurance things get dealt with? And the idea is to get a client's eye view of the procedures. And the reason we do that, well, there's 2 reasons: to get a better understanding of how that particular element of the system functions from the client's view, and as well, so that our health facilitator, who is eventually we're going to put in the probation department, can tell clients exactly what to expect should they get an appointment when they get there. So we did these walkthroughs. We also created, we designed what became called the Healthier You Workbook, which is a workbook of all the different needs somebody on probation might have, health-related needs and other needs, as well as resources and contact information for how to access those services within the state of Delaware. So this was kind of the fun end of the change team process. And then we set up a trial, which I'll go into here, where we're doing some verbal screening, and we're referring people out to treatment at any of those agencies that are part of the change team. So I kind of went through this. We have representatives from 9 agencies. And in talking about barriers to getting people to health care, the biggest thing that came up was motivation. The age of these people is relatively younger, and having been a young man myself one time, when I was 23, you had a hard time explaining to me why I needed to be going to the doctor if I wasn't sick. And these are people with what we like to say live complicated lives. They're busy. They have a lot of appointments because they're on probation. And so motivation was seen as one of the big issues. To address that, we created a series of videos, health-related kind of public service videos. We got people from the community to film some videos, kind of like, why should a young man or a young woman take this stuff seriously and make an appointment and go see a doctor and do so on a regular basis. And we did that. We placed a television monitor in that waiting room at the Wilmington Probation Department, so that those people that are sitting out there are kind of like, if any of you have ever been to the car dealership when you're waiting for your car, you will watch whatever is on that screen up there generally because you're bored, and that's kind of what we tapped into. And so we have a number of health videos and kind of things, public service videos, to try and encourage people and get them thinking about health care. We also put posters up on the wall. Screenings every man should have, screenings every woman should have, again, to create kind of a culture in that room of health, if you will. And then we set up a randomized controlled trial. And what we're looking at here is the difference between, we placed a healthcare facilitator in the probation office who is going out and talking to people from the waiting room and doing a brief screen. It's actually a survey that we designed that just goes over types of health conditions, goes over whether you have insurance, whether you have a primary care doctor, the last time you've seen a doctor, those types of things. We're using that to create a motivational interview and then to make appointments for these folks to go see a healthcare provider, that being the key outcome. If housing or one of those other issues comes up, we can make appointments for them to see one of those folks as well. And so what we wanted to see was the impact of having that person in there. And so we did this, if I can get the slide to move. And what we wanted to test as well was whether having the video running and the posters and all that stuff and just providing the Healthier You workbook, and there's text in the workbook about the need for screening and the need to have a general care practitioner, providing that to people would be enough to get them to motivate and make an appointment on their own. So the two conditions that we have that we're looking at in the pilot trial are whether having a health practitioner on site can get people to make and keep appointments at a general care practitioner service, and we're testing that against whether or not just providing a workbook would be able to do that. And so that's kind of what we're up to. So the design is here. We are randomizing 400 people on a 2x2 design, and the conditions there again. The data we're getting are electronic health and medical data. We're getting Medicaid data. The University of Delaware has access to a behind the firewall tool to query Medicaid data. So the people enrolled in the study, we will be able to see, at least for those that are on Medicaid, whether they utilize services to see a general care practitioner in the 3 months following the contact, baseline contact in probation. We're also collecting survey data from probationers at baseline, and we have direct loop feedback set up with the various agencies. So if we make an appointment for somebody up there, we'll be able to see whether they actually were able to keep that appointment. As part of the study, we're interviewing 80 people, 40 from each condition, largely to get qualitative data on the types of barriers and issues people face out of this population in accessing health care. So we're randomizing using an EARN program that stratifies on gender, race, and age, with the cutoff being over 25 and under 25. There's kind of the design slide in motion there, the 400 on the left, you can see. So we're randomizing, if I can make a little arrow work, there we go. We're randomizing 400 people. 200 of those folks are making up the Delaware Culture of Health with referral group, and 200 of those people are making up the workbook-only condition, and the difference being that in the Culture of Health condition, the clients meet with a health resource facilitator, and that person can make an appointment for them right at the time of that discussion. We work with the agencies to get special phone numbers so that if the health facilitator, if she calls up, she goes direct in and is able to set up those appointments pretty much on the spot. And as opposed to the workbook where clients are encouraged to make appointments, but there is not that direct link. And the 200 out of each group, we're looking at to see really the main outcome is, did they present for appointments at a healthcare facility following the baseline. The stuff in the middle there is the qualitative study that we have built into this. And so that's kind of what we set up to do. So, preliminary report. What are we finding? As of September of 2017, we had randomized 112 people. The sample is 70% male, 66% minority, 11% Hispanic, about what we expected to find in a probation population in the state of Delaware. The randomization is occurring well. We've got 58 in the workbook control condition, 54 in the culture of health condition. And out of the culture of health condition, we have made 36 appointments. So out of the 54 people who saw the health facilitator, 36 of them set up an appointment on that day. Of that 36, only 3 were kept. So here is the first problem we're kind of seeing in the study, is that we had 36 appointments, 3 is kept. This is not really what we were hoping to see. And so we went and talked to the health facilitator who we have on site there, who's been part of our team for a long time. And what she told us is that in conversations with the clients, they recognize the benefit of having a general care physician, and that they do intend to keep the appointment when the appointment is made. But then post-appointment, the ones we've caught, this is not from the interview data, but because we're up there all the time, we see the folks out in the waiting room, and we've talked to some of them, and they tell us they meant to go, things came up. My sister's baby was sick, and I had to watch her. The transportation I had set up fell through that day. So that, they meant to go to the appointments, but they didn't follow up. So we brought the team together. Well, the teams kept meeting. The change team has been meeting on a regular basis, not as much as at first. But we brought the team in, and we did some more brainstorming on how we could get people to keep these appointments, how we could improve that. And we're looking at a number of things, one of which is the use of incentives. You may recall that I said one of the arms you could apply for under the Systems for Action program was the use of incentives in health-related work. We didn't apply for that, but the health practitioners on the change team said, could you offer an incentive? It might be that if we could give them some kind of a carrot to get them up to that first appointment, it might increase the likelihood of them getting there. The idea being, especially for the Christiana group, which is where most of the folks are wanting to go because what they want is a general care physician, they have their own health resource people up there. And so when you come into the Christiana system, you meet with one of these people, and they go through they do a needs assessment on you that looks at housing, transportation, a lot of these issues. But they also offer services that a lot of people don't realize they may be eligible, including dental, vision, and things like that, which are things that younger people may be more enticed to engage in. So the health practitioners on the team are of the opinion that if we can get them there, we can keep them there, and that using incentives on the front end to get them up there was a worthwhile thing to do. We checked with our program officer, and they said that was fine to do within the approach. It was kind of within the Systems for Action thing, and it wasn't going to change the budget too much. So we went forward. We had to go back to our IRB because we were modifying the design. We got the IRB approval in October, and we have just now in the last 3 weeks gone back into the field. We pulled out of the field in September when we saw what was happening because we were doing fine on the front end, fine on recruitment. We knew we didn't have a problem there. We wanted to stop and revisit, and we have just gone back into the field, and what we've done is we've added an arm to the study. So here is the slide that I showed you a few minutes ago. I'm sorry I couldn't get it to paste in. So I just put in the graphic. So the background's a little different. This is the identical slide that you just looked at a few minutes ago, with the exception of this right here. What we are doing is within each of the condition, in that culture of health condition and within the workbook condition, we are re-randomizing. So we're now doing a 2-stage randomization. And within each of those conditions, 75 people are being offered a $30 incentive, wherein if they make an appointment and keep the appointment and keep the visit with a physician, they are eligible for a $30 gift card that they can then pick up when they come back to probation. Nothing else in the model has changed. So what we're testing now is whether meeting with a facilitator and the use of incentives increases the likelihood of you getting to a healthcare person, or the workbook plus incentive or with no incentive. So we've changed the design. It's going to impact our power a little bit, but because it's a pilot, we think we're going to be okay. We're going to get at least 75 in the incentive condition. The reason it's not perfectly balanced is because we've already randomized 100 and some people. We're not going to re-randomize those folks, so they by default fall into the no incentive condition. We're continuing to track those folks, and they will be part of the study, and we're collecting the data so that we'll be able to parse out when people were enrolled, who got what. And one of our colleagues said it might be interesting now because if you think of it from sustainability, if the workbook plus the incentive is getting them there, then for sustainability, not having to pay a health resource facilitator, if you can just give them a workbook and a $30 incentive to get them up to the doctor, that might be well for other probation offices, for generalizability, and for sustainability. So that's kind of where we're at now. We're back in the field. We're also meeting with the change team. We have reached a point in the study where we've begun discussions of sustainability, having great faith in our ability to, one way or another, get people up there, and we're making progress on that. We think we're going to be able to sustain this through a number of methods. But it's not going to be worth sustaining if we can't make it work, so we're still concentrating most heavily on that. Now, with a little bit of time that I have left, what I'd like to do is show you, as I said, we're doing a baseline. We're collecting survey data at baseline when we sign people up for the study. It's a little 2-page thing. We're collecting some health-related data. And again, the sample's not that big. What I'm showing you here is from 112 people who have filled out that survey. And what we wanted to know were why you have not had a regular doctor. And what we're seeing there, first of all, is that 43% of them do, which was actually higher than I would have thought. When we talked to folks, a lot more of these folks than I anticipated do have a general care practitioner that they see. But still, if 43% have them, 67% don't, or 57% don't. So why don't they? Some of them just don't know how. They noted time constraints, not having insurance, and 3% are worried about what they would find out, which is kind of troubling to me. And we may try to deal with some of that to the extent that we can in the qualitative data that we're going to be collecting. Then the next part of the slide there is the percentage of people reporting that they have certain conditions. This is self-report, been told by a doctor that you have, and you can see some of these numbers are strikingly high, with depression and anxiety being the highest too. We've got 13% reporting HCV, which is certainly a troubling number. I'm not going to go through all of these, but you can kind of look down there. And clearly this is a group of people that is at risk and should probably be in touch with a physician. Here are some more outcome slides. Where do you normally go for medical care? Again, we've got a higher number than I would have anticipated, but still low by general standards. 52% go to a primary care doctor. The one that is worrisome for our healthcare professionals that are part of the team is this one here, the 30% who are going to the emergency room. Because folks showing up in the emergency room for things like flu or general things that a general care practitioner can take care of is expensive and troubling for the system. And then we have, do you currently have health insurance? Only 14% said no. Which was, again, a little surprising to us, but 72% of them, their insurance is Medicaid. So this is largely a Medicaid population that we have here. So we're getting at some of this stuff resulting from some of the disparities that we see in the literature and that the study is trying to address. And on the last thing I want to show you here, again, this probation office is in the city of Wilmington, Delaware. And the city of Wilmington is kind of in the midst of a violence crisis right now, where we have very high rates of shooting and very high rates of homicides. And because we were accessing this population, we wanted to collect some data on that. So we put some questions on there, generally looking at things revolving guns. And so you can see there, the top part of the slide is We asked if you knew anybody who had been injured by gunfire, and 28% of them, a family member, had been injured by gunfire. 23% a close friend, 16 someone in the neighborhood, 4% others. These numbers are strikingly high when you think about it in terms of post-traumatic stress disorder, and may explain some of those high numbers of anxiety and depression that we saw in one of the other slides. We also did, as part of the survey, a brief PTSD screen. And what we did is that if you answered yes to anything here, that is, if anyone you know had been injured by gunfire, we asked them to fill out these 4 screening questions. And these are all. This is part of a short PTSD screen. So we're running that up there. And what we have, 48% of those who responded affirmatively to the gunfire question exhibit one or more of the potential markers. 22% had 2 or more, 11% had 3 or more, 9% had all 4. And what that is indicating to us is that we've got a group of people on probation in our probation departments at quite high risks of PTSD that is directly resulting from the violence they're experiencing in their neighborhood. That's kind of not the purpose of this current study, but it is something that we plan to address and are thinking of ways that we can might be able to address that particular issue. And again, because this is a population who is regularly and consistently at a place where health practitioners are able to access them and leads to the potential to be able to link them to adequate care. And so I don't know if I went over or whether I don't have a clock in front of me, so hopefully that was somewhat informative to you all. I hope I didn't talk too fast. I tend to. But I think we do have some time for some commentary and hopefully for some questions. So I'll turn it back over to you folks.
All right. Thank you, Daniel. Thank you, Christy. And so before we get to the commentary, I'd just like to remind everyone that if you have questions about the presentation, you can type them in the lower left-hand corner of the screen, the chat box, and we'll try to get to that if we still have time at the end of the webinar. So for today's commentary, we have Dr. Glenn Mays, who directs the Center of Public Health Systems and Services Research at the University of Kentucky and Associate Director of the University of Kentucky Center for Health Services Research. He also directs the Robert Wood Johnson Foundation System for Action National Program Office, which studies ways of aligning medical care, public health, and social service systems in ways that improve health and well-being. Glenn was also the founding director of the Public Health Practice-Based Research Networks program, which brought together more than 1,000 public health agencies and researchers from around the nation to study innovations in public health delivery. He also established the National Longitudinal Survey of Public Health Systems, which since 1998 has followed a nationally representative cohort of U.S. communities to examine the implementation and impact of multi-organizational public health and prevention strategies. So with that, I'd like to turn it over to you, Glenn.
Great. Fantastic. Can you hear me okay?
Yes, you're coming out loud and clear.
Oh, great. Fantastic. Well, again, so thank you so much. This has been an excellent presentation. Thanks to Dan, his colleagues in Delaware for giving us insight into this very important study, very exciting work, still underway. So I guess I'll start just with some thoughts about the significance of this research. I think Dan, I think made a great case for the rationale for the program and the strategy being tested here. And as he mentioned, we really do have some pretty significant knowledge gaps about how best to connect the probation and community corrections system to the variety of other health and social services systems that can potentially meet the needs of justice-involved populations. And I think the strategy that this group has come up with of meeting people where they are in the probation system, but bringing together this constellation of expertise across the health and social sectors into a change team as a strategy for identifying unmet needs and then getting people connected to the services that they can benefit from. I just think there's enormous opportunity for us to learn from the strategy being tested here. Clearly, it fits squarely into the realm of the work that we're trying to do through Robert Wood Johnson Foundation's Systems for Action program. We're testing mechanisms for connecting health and social services delivery systems in ways that can improve population health. Again, the change team mechanism that is under study here is a very important mechanism that I think we're going to be able to learn from over time. A few thoughts about the kind of the what's been learned to date through this program. I guess thought number one is clearly you've got this group has already been able to show proof of concept here. They've been able to show feasibility of bringing this diverse constellation of actors together, getting them on the same page, and getting them to implement kind of through a collective action strategy the innovative mechanism for system alignment here. So I think that's a very important success that this study has already achieved. You've been able to design the strategy collaboratively, bringing together a really impressive array of organizations in public health and medical care, in a variety of social services, getting those organizations to the table, working with them through a collective action process to design a strategy, figure out where the resources are going to come from to implement that strategy, and then to implement it. Again, implementing it specifically in this probation population. So that's an enormous success that I think I hope the Delaware Collaborative is celebrating that success as a first step, and I think we all should. That's something we can learn from right there. The implementation success and the kind of early proof of concept success that this project has already generated. Secondly, I think the finding that Dan highlighted here around the low rate of actually getting people to connected in and getting people to show up and utilize their appointment to the healthcare system is another very very important finding. That's that's something that you wouldn't know without having generated the earlier success around implementation here. That's the benefit of succeeding with implementing your model, getting it designed and implemented. Is being able to discover the next challenge, the next barrier, or the next system misalignment problem that you've got to address there. And so I think that's obviously a very important finding that your team has been able to detect early, and also been able to continue the innovation process. Use your change team to think about, okay, what's a potential solution to this next challenge in the system alignment process. And I think the strategy that you've come up with and now built into your pragmatic trial here of adding in an arm for incentives is a very smart one, and one that we're going to obviously be able to learn from as well. So another big success there with your early finding and feeding that finding back into your system, back into your collaborative collective action change team, coming up with a solution and then working that into the design. I think is a great example for us all who are doing this work around system alignment and systems change. A third thought I have, just in thinking through the process here, and I think again I think the potential solution here around the design of incentive is a logical one, and one that's we do have a growing body of evidence suggesting that incentives could be quite effective, particularly if I would say I think one place where we've seen incentives be particularly effective is in when there's kind of a in the behavioral economics field, when there's kind of a decision failure that relates to a time inconsistency. So if these healthcare appointments are made primarily to address kind of preventive issues that are on the horizon, but probably in the distant horizon for these for the populations being served here. All of us, we tend to discount the future and respond more immediately to the present benefits and constraints. And so, if these are mostly preventive care appointments that are being missed, I would say that the literature would say the incentives would be particularly helpful in helping to address that time and consistently, creating an immediate reward that will mitigate some of our human tendency to kind of discount the future, so that's a possibility there. On the other hand, that's not the only reason why, potential reason why people are failing to follow through with their appointments. Dan mentioned this is a population that faces a number of health and social challenges, and so it's likely that there are a variety of other social conditions that are posing challenges for people to follow through with their connections to the healthcare system. So I wonder whether there's an opportunity here for, again, going back to your multi-sectoral change team and thinking about whether there are some other resources that some other members of that change team could bring to the table to potentially address other barriers that your participants may be facing in connecting to the healthcare system. You mentioned transportation. You mentioned child care issues. You mentioned potential issues around employment that can create barriers, changes in shifts, and not getting paid time off to visit doctors, or being a new employee and being on your probationary period, so you not having those flexibilities. But again, you've obviously the strength of your design here is you've got experts in those other areas. You've got housing, you've got transportation, and potentially other players there. So it might be interesting to also explore whether there's opportunities for identifying some of those social barriers and maybe trying to mitigate some of those social barriers up front for this population. Giving them, navigating them to transportation or child care resources as a first step that may then reduce some of the barriers to connecting them into the healthcare system down the road. It just strikes me that may be something to kind of explore further, and looking at maybe a deeper probe into some of the reasons for those missed appointments. If they're unmet social needs that are popping up and creating new barriers to connecting to the healthcare system, maybe there's an opportunity for trying to mitigate some of those unmet social needs up front first, before you even try to get them connected into the healthcare system. So that's another thought. The other thought I wondered about, just in thinking about the healthcare system and what's happening, innovations that are happening in a parallel fashion in healthcare. A lot of our healthcare organizations are advancing in their testing of non-visit-based modes of healthcare delivery, using telephone-based and electronic modes of consulting with patients. Again, particularly for routine care, preventive care, and self-care types of strategies. So maybe over a longer term, that could be potentially another solution to test around mitigating barriers to completing healthcare appointments. If appointment availabilities are mostly between the hours of 9 and 5 and Monday through Friday, those are challenges for just scheduling challenges for a lot of people, particularly people experiencing the kind of time poverty that this population does. So there might be an opportunity for your healthcare system to also innovate around again, some non-visit-based, non-personal visit-based ways of delivering care. Telemedicine, telephone-based, using mobile health applications as a way to perhaps connect this population in, at least for their early visits, get them into care, establish a relationship, and then maybe that makes it easier to to maintain them in healthcare over time. So those are just a few ideas that kind of popped into my mind as I heard the presentation and the findings to date. But overall, I'm again very, very excited about this project. I think there's a lot that we're going to continue to learn as this trial continues to proceed, and I really look forward to hearing more from this project.
Thank you, Dr. Mays. Dr. O'Connell, Dr. Visher, before we get to the questions and comments from the audience, we want to give you some time to respond to the comments from Dr. Mays.
Thank you, Glenn. I appreciate it. Appreciate it very much. We have, I echo what you said up front about demonstrating the feasibility, the proof of concept stuff. The change team itself came together and did very well and fashioned a way to okay, how are we going to do this? What's going to be needed? They really, really, really came together and to make the front end of the thing work. And so that was wonderful. And you also mentioned later on, one of the things I really like about Change Team is that they don't go away. Those people are all still there. So as we're conducting the study, we're meeting, we're feeding back to them what we're saying. We say, what do you think? What do you, and brainstorming on it. And so we've talked about, we did the first round of brainstorming on the lack of the low rate of appointment keeping. And so we're doing the incentive stuff, which is good. Some of the other things that we have been thinking about, and that's what you kind of got to at the end, was other ways beyond, a monetary gift card incentive that could break down some of those barriers. And we've talked to them. The Christiana group has talked about their ability to potentially place their health navigators down with us at certain times, so that, like right now, our facilitator, Judy, she meets with the person, she makes the appointment, and then the person has to keep that appointment. We might be able to, we've talked about being able to set up either making an appointment that would take place at the probation office at the client's next probationary visit. So if somebody's coming in every week on Tuesdays at 2, and she sees Judy this week, we might be able to do that initial appointment the following Tuesday at 2 and have the health navigator from Christiana down there at that time. And it gets to that familiarity with the folks. They would be able to discuss all the types of services, be able to get the insurance stuff done, those things, which creates that initial link to the health, the practitioners. So we're investigating the possibility of doing that. The problem I'm going to get into, this is where research, we're going to get to a point where we're going to muddy the water on the design. So if I now bring the health navigators down, that essentially creates another arm of the study. And so we're going to have to deal with how that's going to work. Dr. Visher's throwing notes at me because she's sitting here with me. And she said, wait, it may be that we have to run the pilot trial now with what we have to see if the effect of the incentives is working. But as part of what the change team was tasked with in the beginning was that whatever we developed, we needed to develop something that could be sustained. We did not want to go up there and do our little research thing and then pull out and have it go away. We want it to remain after we leave. And that gets to some of the stuff that Dr. Mays was talking about. So we've talked about the health facilitators from Christiana coming down. We've also been in conversation, and again, this is more on sustainability rather than increasing the immediate linkage, but it feeds into both. We've been in contact with the Division of Health and Human Services about providing some of their folks. They've got social workers on staff, and it's kind of two conversations. It's funny because members of the change team, of course, are on different committees in their jobs, and one of the DOC people on the change team was in a different meeting talking about whether they might not be able to expand access to services, and they told them what we were doing as part of the RWJ Systems for Action project, and they said that sounded like an interesting model, and so we're going to have them come in and see if we can kind of meld this or have this evolve into, in my head, as the trial ends, what we're working towards is having social workers from the Department of Health and Human Services take over where our health facilitator is, and have that happen in tandem with the health navigators from the Christiana Care. So we would have direct general care folks in there, as well as people from the DHSS team in there. And what we're hoping, one of the outcomes of the study being, is that this morphs into that kind of a model, which they would then hopefully understand that what we've learned about getting people to the thing. The last thing Dr. Mays talked about was the telemedicine kind of thing, which had not occurred to me at all. It really hadn't. I hadn't thought about it in this particular setting, and I'm going to take that to heart, because this might be an ideal place to implement that kind of stuff and see if that can't get those initial contacts to take place. Christy's waving at me and saying that we're running out of time, so I'm going to go ahead and turn it back over and open it up for other folks.
Yeah, so we have about 3 minutes left, and we have 3 questions. I'll just bring them all up so you guys can answer them. So the first one was from Jason. How has the project been received from the supervising probation officers, and what kind of impact has it had on the workload? There was a question from Megan. Have you solicited input from the probation population on the study design, and what have your been efforts to include them as partners in the research? And then there was another question from Kirsten. Are you looking at healthcare costs in your trial or other system costs like criminal justice costs? So those were the 3 questions that we had from the audience, and you have a few minutes to address them.
I'll take them really quick. What do the probation officers themselves think of it? They're generally open to the idea. We see them all the time up there. They know what we're doing. They think it's good. They are somewhat skeptical about our ability to get these people really to do anything. They're a bit of a jaded group, but they encourage us, and they kind of like the effort. Soliciting feedback from the probation population. We don't have a formal element other than the qualitative surveys that we're doing on that. But in working with the probation population, we did not necessarily have them in front at the study design, but we have been talking to them as we go through. And we talked to them about the use of incentives, and they seem to think that would be a worthwhile thing to do. We're not doing a cost study as part of this. Generally, what we want to do is first see if we can get the model to work, and then we would probably try to revisit it down the road as we expand into a fuller trial, if you will. We would build a cost element into that. And I think I've got 30 seconds left, so I'll hand it back.
Thank you, Dr. O'Connell. Well, that's excellent. And if anyone else had any more questions about the presentation today, you can also forward those questions directly to Dr. O'Connell, Dr. Visher, or even through us at S4A, and we'll forward it to them. So once again, we'd like to thank our presenters for today, Dr. Daniel O'Connell, Dr. Christy Visher, and also our commentator, Dr. Mace, for your time and presentation today. We'd like to, again, remind everyone that today's presentation is available for download as with past research in progress webinars. You can find them at the Systems for Action website. And we'd also like to invite you to take a look and also invite you to join us for our upcoming research in progress webinars. So the information for that will also be available on the Systems for Action website. So we want to thank once again, all our presenters and our commentator, and for the audience for joining us today. We hope you have a great day, and we hope to see you next time. Thank you and goodbye.